This ECG is easy to diagnose, but can you prove it? Hello everyone, welcome to the Rhythm Files episode 4. Let's see what this case is about. A 68-year-old male was brought to the ER with chief complaints of palpitations, shortness of breath, and fatigue. He has a past history of hypertension and peripheral arterial disease on medications. Vitally, BP is 110/68, pulse is 146 but is irregular, SpO2 is 94%. On CVS examination, there is variable S1 intensity and RS shows bilateral crackles. Let's look at his ECG now. Try to ascertain the QT interval, the presence or absence of P waves, the QRS complex. We'll have a closer look at this. Try to diagnose it now. Right, so this patient is a case of atrial fibrillation with rapid ventricular response since the heart rate is more than 100. Now, to calculate the ventricular rate and atrial fibrillation, we check the number of R waves within 10 Lat squares and then multiply by 30, or we check the number of R waves in 30 Lat squares and then multiply by 10. Now, let's look at the characteristics of this ECG. So, here we get an irregularly irregular rhythm, absent P waves, fibrillatory F waves, narrow QRS complex, variable ventricular rate, and no distinct PR interval because obviously P waves are absent. Now let's look at the rate control techniques in this patient. So in acute rate control, the main goal is rapid symptom relief. Usually beta blockers, verapamil or diltiazem are used. Digoxin can be used for a short period of time. In this, the heart rate targets are not very strict initially. But in chronic rate control, the target heart rate should be less than 80 at rest or less than 100 on mild exertion. But up to 110 is acceptable. Here, the target is to prevent tachycardia-induced cardiomyopathy. Overall, the best intervention is AV nodal ablation plus cardiac resynchronization therapy because it improves the overall quality of life and the prognosis. Now, in this section, I've highlighted certain key points regarding the anticoagulation that needs to be done in candidates of cardioversion. So, two approaches are used generally, the conventional one and the TE guided approach. In special situations like the LA closure device, electrical cardioversion is possible without oral anticoagulation if the echocardiography shows good device position, if there is no device related thrombus, and if the peri-device leak is less than 5 mm. So this is the high yield summary of atrial fibrillation. Always check the SHA2 DS2 VASC score for stroke risk assessment. Thank you. Please like and follow.